All right, so thank you for joining us for week 5 of the Supportive Housing Field Response to COVID-19. A quick word about CSH before we begin. We are a national organization with regional offices and staff throughout the country. We focus on supportive housing and housing solutions to improve the lives of vulnerable people. We also help communities maximize their public resources through creating supportive housing, and our ultimate goal is to build strong, healthy communities. We have several ways that we're keeping everyone connected in the supportive housing field during the crisis. If you look at our website, csh.org, you will see a big banner connecting you to COVID-19 related materials and resources. We're also sending out a weekly e-blast connected to COVID-19. We have a community platform that I will send out a link to after this webinar. We're doing this weekly webinar series, and we also have an email at chcovidinfo@csh.org. Feel free to email that address if you have any COVID-specific questions for us. And with that, I'm going to hand it over to Marcella.
All right. Good afternoon, everybody, or good morning. Welcome, everyone. My name is Marcella McGuire, and I'm CSH's Director of Health System Integration, and I've got the privilege of introducing today's webinar presenters. So, Lisa, I want to hand it off to you to give us just a quick hello.
Yeah. Hi, everyone. My name is Lisa Johnson, and I'm the Statewide Case Management Director at Brilliant Corners, and I'm currently sitting in my apartment in Los Angeles doing this webinar.
Hello, everyone. This is Alicia Bond, team leader from Pathways to Housing PA. And like Lisa, I'm currently sitting at home joining this webinar for you all.
All right. Well, welcome to you both. All right. Next slide, please. So each week we come together to support each other during this crisis, highlight some of the best work that CSH is seeing nationwide in the field, better understand what communities are struggling with and how best to address those challenges in future materials and webinars. We'll continue to be doing this series for the foreseeable future as long as the crisis continues. Next slide, please. We know that agencies are struggling with home visits. How do you keep your staff and your residents safe? How do you make sure that your residents receive the services they need to maintain their housing, address their healthcare needs, and maintain social distancing? We know that balancing of all those diverse needs is incredibly challenging, and we're privileged to hear from their wonderful teams at Pathways Pennsylvania and Brilliant Corners to hear how they are addressing those challenges while continuing to live up to their mission. With that, I want to turn it over to Elisa to hear how they're doing it here in Philadelphia. Next slide.
Thank you. Before getting started with telehealth, I want to share a little history of Pathways with you all. In 2008, the city of Philadelphia engaged Pathways to bring the evidence-based housing first model to our city to help end chronic homelessness. We operate a scattered site program and currently house over 450 single adults who have experienced chronic homelessness and who are diagnosed with a serious mental illness and or substance use disorder. Our mission is to empower people with disabilities to improve their housing stability, achieve better health, and reclaim their lives. We have an 85% housing retention rate after 5 years with clients who were considered not housing ready by other programs. Pathways operates 6 non-Fidelity Act teams and 1 step-down blended case management team. 3 of those teams, one which I lead, specifically serve individuals with opioid use disorder or polysubstance use disorder. Pathways was the first agency in the country to utilize the housing first model in a scattered site setting with those using opioids. Telehealth has been a really important tool to aid us in staying connected and supporting our participants during the COVID pandemic. Before COVID, our individuals had the option of engaging with us daily. Pathways offers office hours from 10 a.m. to 3 p.m. in which participants could come in, meet with their team, socialize with their peers, or even engage in a community inclusion event. Our individuals are visited at home at the minimum once biweekly. At the start of the pandemic, and in an effort to reduce staff and participant exposure, we reduced our face-to-face contact and increased our telephone support utilizing our tier system, which I will provide more details on shortly. Telehealth has allowed us to provide virtual support to our participants in ways that face-to-face engagements would usually occur. In replace of face-to-face visits, we have begun virtual home visits, symptom screening, connecting our primary care providers, and addressing mental health needs by connecting our participants to our behavioral health specialists and psychiatrists. In efforts to make our telehealth and virtual visits as successful as possible, Pathways purchased prepaid cell phones and provided them to participants who did not have access to a phone. Although telehealth has been a success for us, there are instances where a face-to-face visit is still warranted. I'll give you an example. Pathways continues to provide housing for our new engagements. This includes virtual tours of apartments, arranging telehealth appointments with our psychiatrists for psych evaluations, and moving in a participant once they have selected an apartment of their choice. In addition to the new engagements, our service coordinators and nursing team will provide face-to-face visits for any individual that requires it. I'll give you another example. If a participant needs support accessing a food resource, or if the participant is not responding to the telephone support, or let's just say they require our intervention for a non-COVID related illness by one of our nurses. You're probably figuring out at this point, how do we provide or determine what's a face-to-face visit or a telehealth visit? Each of our teams meet daily for our rounds. Rounds occur at the first hour of our day over Zoom. Every member of the team, including the team leader, assistant team leader, service coordinator, substance use specialist, certified peer specialist, and nurse are present. Our psychiatrist, Dr. Hills, and behavioral health specialists attend at least once a week to provide additional support. During rounds, we review our entire caseload, briefly discuss their needs, and create our schedule. Each day, a service coordinator is assigned a face-to-face day. In addition to rounds, the nurses meet right after to review the medical needs to our participants and focus more on our medical tier system. Next slide, please. So our tier system, we have it in 3 different tiers. For tier 1, those are our most acute individuals. They're individuals who have unmanaged chronic health conditions and require frequent engagement with our nursing team, some as often as daily contact. For tier 2, we can call them our subacute team. They have managed chronic illnesses and require less frequent contact with nursing. For tier 3, they are our stable individuals who are able to manage their health independently, take their medication as prescribed, and have very minimal interventions with our nursing team. Next slide. So, determining our visits. For tier 1, as I mentioned previously, these are our most medically fragile individuals, so we like to engage with them more often. We contact them at least 3 times a week via phone, and after 2 unsuccessful phone contacts, a face-to-face visit is completed. I'll give you an example. Say a staff member places a call on Monday and they don't get an answer. Tuesday, no answer. By Wednesday, a member from the team is going out to engage face-to-face. But tier 2, we're contacted twice a week. And just like tier 1, after 2 unsuccessful contacts, someone will go out face-to-face. Keep in mind, Tier 3 are our most stable individuals, so we have less frequent contact, about once a week. Although we use our tier system as a minimum basis for contact, we can increase our contact if the participant needs additional support. What we have learned that many of our participants have experienced increased anxiety, like ourselves, during this pandemic. To ensure we are meeting their needs and providing the levels of support that they need, we have used our telehealth system to socialize with our peers. It's important to us for our individuals to know that although they may not have the flexibility of office hours to socialize, we are still able to engage with them in those same activities utilizing our telehealth. We have used telehealth to engage them regarding peer activities such as peer party line, recovery meetings, and also supporting them with registering to vote and completing the census. Since COVID-19, things have not been business as usual for Pathways, but our goal is to keep our staff and participants safe and inform them what is going on. To assist our service coordinators and other members of our team, we came up with a symptom screening in which I have a script to share with you all. Next slide. These are our COVID-specific questions that we like to engage our individuals on at the start of any visit, whether that's a phone contact or a face-to-face. Have you had a fever? Have you had chills? Do you have a new or worsening cough? Have you experienced shortness of breath? If anyone answers yes to those questions, during a home visit, we ensure that a participant puts on a mask and connect them with our team nurse. If during a phone call, a participant answers yes, we connect them to our team nurse or primary care. If anyone answers no, we still like to follow up on additional things, such as, are there any issues with your apartment? Are there any needs for repair? Are you taking your medications? What are the names? What do they look like? How many are left? Do you need any refills? Do you have enough food for the week? What are you doing during this time to stay busy? We provide resources whenever necessary. We like to check in with our participants and see how they're doing and provide brief education during this pandemic. We will remind everyone that the main symptoms are fever and dry cough. Sometimes people can become very sick and feel shortness of breath. The best way is to stay home and to stay safe, avoid crowded places, including public transportation. Make sure you wash your hands with soap and water, especially right before you eat and after you go to the bathroom. Try not to touch your face, especially your mouth and hands. If you don't feel well, please contact your team. If you're experiencing shortness of breath, please call 911 or go to a hospital. We have been implementing these strategies at Pathways for about 6 weeks now, and despite some hiccups and a little bit of a learning curve, things seem to be going very well. Our participants are still engaging with us regularly, and we're able to triage and respond to developing concerns in an organized way. So I hope this information will prove useful for you all at your agencies, and I'm happy to address any questions during the Q&A in a few minutes.
Great, thank you, Alicia. So hi everyone, I'm Lisa Johnson and I oversee our case management department at Brilliant Corners. Brilliant Corners is a supportive housing nonprofit that works statewide across California, providing an array of innovative supportive housing programs and services. So when the COVID-19 crisis hit, Brilliant Corners mobilized quickly in coordination with our many funders and partners to determine best practices for serving our existing clients, and then also continuing to get people into housing during COVID-19, because we all know that people are safer in their own homes than they are in shelters or on the streets. So today I'll share with you highlights of how we shaped our response and adjusted our protocols, some of the guidelines we created to keep our clients and our team safe, how we're supporting our clients through this crisis, and how we're working to prioritize move-ins for clients who are most vulnerable to COVID-19. Next slide. So in early March, we had a number of conversations with our partners to ensure that the strategies we were developing as an organization were aligned with our funders and partners' expectations. So this ranged from funders who wanted to stop home visits altogether out of an abundance of caution to some funders who were still requiring in-person visits. And we worked to advocate for responsive protocols that protected the health and safety of both our clients and our staff. We received really great guidance from the medical director of the Housing for Health Division at the LA County Department of Health Services, who provided really clear recommendations for case managers really early on in the crisis. Her guidance helped inform our process of reviewing caseloads so that we could prioritize which clients needed in-person support and which clients we could switch to telephonic support. Across our entire housing services portfolio, our housing coordinators and case managers audited their caseloads to determine each client's level of vulnerability and how our supports could be best tailored to their individual needs. So for many clients, our team moved to phone check-ins to reduce the likelihood of transmission and increase the frequency of those phone calls to mitigate the fear and isolation that our clients were likely to experience due to the pandemic. Staff educated clients about the risk of COVID-19, so they understood why we were shifting service delivery and how best that they could protect themselves. Next slide. So with support from our partners and funders, we provided guidance to our staff on when an in-person visit is indicated. So this guidance was differentiated for our housing coordinators and for our case managers, because for case managers, more field work is needed given the intensive nature of the role. We also created guidelines informed by recommendations from public health agencies on how to screen for COVID-19 prior to an in-person visit, and then the next steps to take based on the client's response, very similar to what Alicia outlined in her earlier slide. We also created a best practices guide for conducting in-person visits and mapped out what that would look like. So including things like social distancing during those visits, meeting outside whenever possible, and prepping all documents in advance. We did get very detailed in the best practices and gave some really concrete examples to our staff, like recommending for move-ins, printing 2 copies of the lease so that both parties could review the document 6 feet apart and make sure social distancing could still occur. And then also reviewing the lease over the phone before the lease signing whenever possible so that the actual in-person move-in could be much shorter. We also emphasized to staff the importance of explaining these new actions to our clients so that the client doesn't feel stigmatized or alienated. We also encourage staff to use the conversation as an opportunity to educate the client on social distancing and other good hygiene practices. We then developed a series of guidelines for staff informed by recommendations from public health agencies on what steps to take if a client is presumed or confirmed COVID positive, as well as the steps to take if an employee is exposed or confirmed COVID positive. And overall, as an organization, we've prioritized moving clients into permanent housing during COVID-19. We've been really creative in finding ways to do this both rapidly, but also safely. Through things like virtual unit showings, where a client can be shown pictures or a video of a unit so that they don't have to go in person to view it. We've also requested lock boxes for keys so that landlords don't have to attend unit showings, and we can remove one person from that in-person meeting. And then, as I mentioned earlier, also doing lease reviews over the phone. Our housing services team across the state of California, despite all of the challenges, we were able to move in over 200 people into permanent supportive housing in the month of March, which is really incredible. Next slide. So I also wanted to share a few examples of how our staff have stepped up to provide services and advocate for our clients across our different programs during this pandemic. So for staff members who are immunocompromised or live with people who are, we have had very clear and open communication from the beginning that they should not be putting themselves or their families at risk. And so we have had other staff stepping up and volunteering to go into the field to provide coverage for their colleagues. This all hands-on-deck approach is very much the Brilliant Corners way. It really speaks to our whatever it takes ethos. People have been incredibly adaptable and are really stepping up in different ways to ensure that our clients have the support that they need during this time. Another example is the no contact deliveries that our case management teams have done since the beginning of the crisis. Our Breaking Barriers team, which serves adults on probation in LA County, tapped into donations and our program funds to provide no contact food and household supply deliveries to their clients. Through an existing relationship with Baby to Baby, another nonprofit that provides low-income children with diapers and basic necessities, we were able to secure a bulk donation, and our case managers have been able to deliver diapers and baby wipes to our Breaking Barriers families through these no-contact drop-offs. Our teams have also been stepping up to advocate for our clients to move into housing whenever possible. For example, in one Southern California region that we serve, our team was able to successfully advocate with our funders and several skilled nursing facilities to approve clients to move from the facilities to independent housing despite the pandemic. Now those clients will not only have more independence, but they'll also be safer in their own homes. For other clients who are unable to move due to full lockdowns at the facilities, we're actually able to hold their units until they can safely move in. And then I'll wrap up today with a story about how we are also working to support our clients at a distance, even when we are unable to safely see them in person. So one of our clients, named Prentice, is an elderly man with chronic health conditions, and he utilizes our case management team for his self-care. So before the COVID crisis hit, he would visit our office almost every day for his self-described pick-me-up, and always would say that his mood improved after these visits. Due to the pandemic, his case manager had to educate him on how the visits could put his health at risk and the importance for him to stay in his home during the crisis. Prentice and members of the case management team came together and devised a plan to check in daily over the phone or via text message, just to offer words of encouragement, tell jokes, and our team has even been able to provide him with some new cooking recipes. Prentice has been really vocal with our team about how much comfort these check-ins have brought him, even though, of course, he would much prefer to come to the office. Prentice's story, for me, is a reminder of the power of connection and how important it is to be creative in our solutions in order to continue providing support during this really difficult time. So thanks so much for having me today, and I'll turn it back over to Marcella and Emma.
All right. Thank you, ladies. We've got some fabulous questions in the chat, so please stay on. We want to hear you. First off, Alicia, are you concerned about the frequency of the face-to-face visits, and do you provide PPE to your staff? That was our first question.
So we're not really concerned about the frequency of the face-to-face. I think that we utilize our rounds as a good tool for us to kind of engage. I also want to be clear that before we engage with anyone, whether that's on the phone or in face-to-face, we're doing those screenings. So let's just say if we go to do a home visit and we're knocking on a participant's door, we're screening them before they are actually answering the door. And so we kind of know. Our staff does have PPEs. We have provided our staff as well as our participants with masks. We have endless bottles, I would say, of hand sanitizer, gloves, and those things. And so we have been very fortunate and very safe during our home visits.
Yeah, I would echo that. We've been able to provide our staff with masks as well. And, I think we are, of course, concerned about the in-person contacts, both for our staff, but also for our clients, especially if they're in one of the vulnerable groups. And for us, it has been really assessing if it's necessary to do that home visit and really thinking about, before we go to do that in person, are there other ways that we can provide this service to minimize that in-person contact? And then if we do need to see that person in person, then how are we doing that safely, whether it's wearing PPE, doing the social distancing, meeting outside, some of those other examples I mapped out, really thinking through how can we do this in the safest way possible.
All right, thanks. So next question I see is that people are asking for copies of some of the materials and some of the that you're referencing, in particular, some of the policies and procedures. Never start something from scratch when you can steal good work elsewhere. So I believe that we had spoken with this, that we'll share the contact info for our presenters, and also know that CSH has developed a community platform. I put the link in the chat. Lisa, if there are any specific policies and procedures you want to share and make sure we put up there so it gets an even broader audience and all the folks on our webinar, we would love to see that as well. We may go a little over the half hour just because I know we want to get to some of these. Can you describe what PPE you provide to staff? I heard masks in some cases, I heard gloves, and I heard hand sanitizer. Is there any other PPE that you ladies want to highlight?
I wouldn't say PPEs. I think that continued education and continuing to check in with our staff, kind of tuning into themselves, checking in with each other's comfort level, and remembering the CDC guidelines, practicing social distancing. I think that, we're not just going into any of these situations blindly. We are definitely talking as a team and developing what takes priority, who is responding to, what. And like Lisa mentioned, whatever can be utilized through our telehealth system, which I think has been an amazing tool for us to remain as successful as possible during this pandemic, we have been doing that. Our participants have been very appreciative of the, new technology and access to telephones and continuing to do things as much as possible during this time.
All right. Emily, do you want to put up the poll? We've still got a couple more questions, but I know we're close to the hour and we're starting to lose people. I want to make sure that we get everybody's feedback on what some of our next webinar topic areas will be.
Sure, absolutely. So opening the poll now, we want to hear from you. Where do you need help? What would you like to hear about? Our options are how communities are using data to address racial disparities amidst the COVID-19 crisis, coordinating with your local emergency management teams, the quarantining hotel model, food resources for your community, or tracking COVID-19 related costs.
All right, and while that's happening, I will continue to try to do some Q&A here. Let's see. One of the questions we saw was, are you continuing to visit people in nursing facilities? Is that something you're finding out? Lisa?
So for us, most of the skilled nursing facilities and residential care facilities are no longer accepting visitors. So our teams have not been able to go into the facilities, and that's for the safety of the residents there. And so we really want to respect that. We have been able to do a lot of telehealth, phone calls, in some cases, video conferences, and our teams are coordinating really closely with the facilities in order to ensure that we can continue to provide services. And in some cases, we are still able to do no contact drop-offs of supplies or other resources that our clients need. We just are unable to enter into the facilities to provide those services for the safety of the residents.
I would agree. I would say the same thing as Lisa. A lot of the facilities around our city are not allowing visitors at the time as a safety precaution for the residents as well as for the visitors. So.
And just one more quick question. We're already over time. Are clients and residents open to meeting virtually as an option to meeting face-to-face? Lisa, I liked your story about that, but, would love to hear broader. What are you finding in clients when you're proposing the telehealth options?
I think we're finding that our clients are really open to switching to phone. I think if there are frustrations, once we're able to explain why and really educate them on COVID-19 and how we are, taking these measures really to protect them as well as our staff, I think that really resonates and helps them understand. And then also just making sure that we're increasing those phone contacts to ensure that we're providing an adequate level of support. I think that's really helped. I think just having those weekly or multiple times a week opportunities to check in with our clients has made them feel really supported, even though we can't see them in person. So even though, of course, there are some frustrations around the lack of in-person, I would say for the most part, our clients have been really understanding and really receptive to the changes we've made.
Alicia, anything to add?
I would say that I think that they have been very receptive. We started utilizing our tier system as kind of like a basis for us. And we recognize that even individuals who are on our tier list who were contacted once a week because of the increased anxiety or whatever their reason it may be, have requested more telephone support, whether that's with a member from the team, the nurse, the psychiatrist, and our behavioral health specialist, which I think has been very good for people to be able to process what's going on. It's a stressful time for all of us.
All right. Thank you. It is, and we really appreciate Lisa and Alicia taking the time today to share their experiences. There's a number of other questions that we were not able to get to, including in particularly people asking for protocols. So Emma, why don't you take that? I know you're going to be sharing some ways that people can get some of those questions answered in some of the materials. I'll hand that back to you, Emma.
Okay, great. So I will be sending out a copy of the slides and a recording tomorrow, as well as some materials that will hopefully be helpful and answer some of these questions for folks, because I think we have some resources that will be really helpful. The poll that won, for lack of a better word, is how communities are using data to address racial disparities amidst the COVID-19 crisis. So really important topic. We're excited to start working on putting that together for you all. But next week is planning homelessness response for after the immediate crisis. It will be Tuesday, May 5th at 1 p.m. And I will send out a link to register for that as well with all the materials and recording tomorrow. So keep your eyes peeled for that. And I just want to say thank you, everyone. Thank you for our presenters today, and just thank you for everyone who's out there working in the field right now. I know so many of you are risking your own safety to support your tenants, and it's just, it's really, really important work. And we're just so appreciative to all of you who are doing that direct service work. So keep it up. Everyone's doing such a wonderful job, and we'll see you next week.
All right, thank you. Thank you, CHS, for having us. And the Marcella, thank you.
Thanks all.
Thank you.
Thanks, everybody. Great job.